We decided to do this research because we wanted to better understand women's preferences for breast cancer screening with mammography. We did this research before the United States Preventive Services Task Force changed its most recent cancer screening guideline for women, ages 40 to 49. And we wanted to understand what age women would want to begin screening when they were informed about both the benefits and the harms of screening and also their personal breast cancer risk. So in this study, women received a decision aid that told them about breast cancer mortality reduction with screening in their 40s, and also told them about false positive results and the rate of false positives, and also gave them fairly extensive explanation of what overdiagnosis is and how often it happens. Women who start screening in their 40s have a higher chance of experiencing a false positive result, and they have a lower chance of benefiting from screening because their risk of breast cancer is generally lower. All women who receive screening also have a risk of overdiagnosis, which is where you're diagnosed and treated for a cancer that would have never caused harm in your lifetime. Some women, when they learn about the evidence, decide that annual or biennial screening starting at age 40 is right for them. But other women, when they learn about the evidence for mammograms, feel differently. Sometimes that's because they have a lower chance of getting breast cancer, a lower risk level, and they want to make sure that they maximize their chance for benefit and minimize their chance for harm. Women who wanted to screen at an earlier age generally were at a higher breast cancer risk and were concerned about things like their family history and prevention. Whereas women who wanted to screen at an older age were more concerned about the harms of screening and also, on average, were at lower breast cancer risk. We think the key takeaways are that women who are informed do have diverse preferences about when they want to begin having mammograms, and being informed changes their preferences. Many want to screen later. And we think that it's important to acknowledge the need to reduce barriers to receiving desired preventive care, but also to respect and support patients' autonomy to make informed decisions. So there was a small number of people in our sample who said they never wanted to receive screening in the future at any age, about 5% of the sample. And after women were informed about the benefits and harms of breast cancer screening, that number actually was reduced to 4% of the sample. So informing women about the benefits and harms of breast cancer screening does not appear to deter people from screening altogether.